Okay, last time we stopped at the closed angle glaucoma. So today we are going to continue our journey with glaucoma. We are going to cover the closed angle glaucoma and the congenital glaucoma, medical, laser, and surgical treatment of glaucoma. So let's start immediately by the closed angle glaucoma. What is the pathogenesis of the closed angle glaucoma? Why does it happen? The closed angle glaucoma, or the angle closure, is defined by the mechanical blockage of the trabecular meshwork. By not everything, but it is just by the peripheral iris. So as we explained the last time, the main problem in the glaucoma is the blockage of the outflow. This blockage of the outflow mainly occurs at the trabecular meshwork, and this trabecular meshwork could be blocked by anything. Could be blocked by cells, could be blocked by pigments, by immune complex deposition, by lens matter, by blood, so by everything. If it's blocked by anything, then this is called the open angle glaucoma. But if it is closed mechanically by the iris, then it is called the angle closure glaucoma or closed angle glaucoma. Like we see here, we can see that the iris is causing a mechanical opposition towards the angle, leading to obstruction of the angle, and this what will result in impairment of the aqueous drainage. Whether the patient will be manifesting or not, this will depend on how many angles are, or how many degrees are obstructed. So we have 360 degrees. Are all of them are obstructed, or if there are only certain area which is obstructed? So we will get to that later. Actually, the angle closure glaucoma is a common disease in Chinese. So it actually accounts for the blindness resulting from glaucoma accounts for like around 90% of blindness in Chinese. So the spectrum of this disease is defined or is categorized into 3 categories. Can anyone tell me how can I prevent the annotation by other members in Zoom? So it happens a lot that someone by mistake just write on the screen, and I still don't know how to prevent that. This happened in the previous orientation, so it was like awkward situation. Nobody knows the answer. Okay, so you don't know any technical stuff. So I'm going to ask you in a medical stuff. Okay, back to the lecture. The primary angle closure suspect, or the PACS, the primary angle closure and the primary angle closure glaucoma. So this is the spectrum of the angle closure glaucomas. Let's see the definition of each one. A primary angle closure suspect, when you are suspecting a patient with to have a primary angle closure, he should have a iridotrabecular contact of more than 180 degrees. However, he is not glaucomatous. There is no evidence of trabecular meshwork damage or optic nerve damage. He is just a suspect. Okay, so for someone of you asked me last time, how can we define a suspect? In angle closure, we have a clear definition for a suspect. This is a person who has iridocorneal contact more than 180 degrees, but no problem in the trabecular meshwork on the optic nerve damage. He will be deemed as, or he will be entitled a primary angle closure title if he has iridotrabecular contact more than 180 degrees and high intraocular pressure. High intraocular pressure. But again, he is not glaucomatous. And as we knew from the last time, the glaucoma, there is progressive optic neuropathy. But since that he is not glaucomatous yet, so he doesn't have any optic nerve damage. He is just having contact, iridotrabecular contact, and high intraocular pressure. If he is becoming primary angle closure glaucoma, then he will be having primary angle closure plus glaucomatous optic neuropathy. So you see, the spectrum is sometimes these definitions are asked in the exams. Please be careful about that. So what is the pathogenesis? Why the angle closure happens? We have 4 different mechanisms. One of them is very common and very famous, which is the pupillary block. So we know that the normal aqueous will pass from the ciliary body through the posterior chamber, through the pupil to the anterior chamber to be drained by the trabecular meshwork. However, in patients with pupillary block, there will be irido-lenticular touch. So there will be a touch between the lens and the iris. This means that the aqueous, which is secreted by the ciliary body, will be trapped in the posterior chamber. It will be pushing the iris forward, and this what will lead to occlusion or obstruction of the trabecular meshwork. So this what will lead to rise of the intraocular pressure, because the aqueous is not being able to be drained through trabecular meshwork as it is trapped in the posterior chamber. So the question here comes, why this pupillary block happens? Why there is a touch or contact between the iris and the lens? This could happen, or this contact can happen not only with the lens, but with anything, like with the phakic lens or the pseudophakic lens, or if there is capsule, could be adhesion between the iris and the lens capsule, or even if the patient is aphakic, it could be a touch between the iris and anterior hyaloid face of the vitreous. Or if there is overfilling of silicone, like if there is silicone bubble in the posterior chamber, and or as a vitreous substitute, and it is pushing everything forward. So it can be caused by all these stuff. So what will be the typical management for the pupillary block to break this vicious circle is to do another opening in the iris, in order to allow the flow of aqueous through this opening. This is called the peripheral iridotomy. So by doing an opening into the peripheral iris, this will result in passage of the aqueous from posterior chamber to the anterior chamber, bypassing the normal anatomical pathway. So this can be done by laser using the peripheral iridotomy, or it could be done by surgery as in peripheral iridectomy. So this is one mechanism. What are the other mechanisms? The second mechanism is angle closure, but without pupillary block. So why could an angle closure without pupillary block happen? So this should be the angle, and this is the iris, and this is the lens. It could be that there is something which is pushing the angle or pushing the iris forward. So there is something from behind which is pushing the iris forward, leading to mechanical obstruction of the angle. What is this? It could be the vitreous. The vitreous, as in malignant glaucoma, there is aqueous misdirection. So the aqueous, instead of directed toward it from posterior to anterior chamber, it will be misdirected toward the vitreous, leading to increasing the volume of the vitreous, pushing the iris forward to block the trabecular meshwork. Or it could be a ciliary body swelling or a choroidal swelling, such as ciliary body tumor or choroidal tumor, which will be again pushing the iris forward. It could be an iris plateau. So the iris itself, it could have, like, it will be pushed forward by anteriorly displaced ciliary body, leading to making a hump. This hump will close the trabecular meshwork. Posterior segmented tumors, as the retinoblastoma, contraction of the retrolental fibers, such as the presence of retinopathy of prematurity or persistent fetal vasculature, as I'm going to show you. This contraction will also result in occlusion of the angle by the iris. Anteriorly displaced lens and encirclement scleral buckle. So if there is a buckle, this buckle will be causing constriction over the equator of the globe, leading to forward push, leading to elongation. It will result in elongation of the axial length of the eye, and displacement, forward displacement of anterior segment structures. So I guess that you can expect what is the next mechanism. It could be an angle closure without a pupillary block, but in this case, the iris is pulled forward in contact with the angle. So there could be something which is pulling the iris toward the angle. What is this? It could be an eye syndrome, as in iridocorneal endothelial syndrome. So there will be endotheliopathy, the endothelium will be creeping over the angle, leading to and making a peripheral anterosynechia, which is pulling of the iris toward the angle. It could be an epithelial ingrowth, so like an incision which will placing the epithelium into the anterior chamber, which make the epithelium will grow over the angle, leading to pulling the iris toward the angle. Iris incarceration in traumatic wound or surgical incision, and if there is any inflammatory membranes or fibrovascular membranes, such as like what happens in neovascular glaucoma, this also will lead to, this contraction will cause peripheral anterosynechia and closure of the angle by this pupil, by the iris, as a result of contraction of these inflammatory and fibrovascular membranes. So this is another mechanism. What is the third mechanism of angle closure? It will be caused by the lens. So we mentioned the last lecture that the glaucoma can be open angle, as in caused by the lens, as in phacolytic and phacoantigenic. And in case of the lens-induced pupillary block, it could be also closed angle. So closed angle, like it will be, could be by one of two mechanisms. It could be a phacomorphic glaucoma, like the lens is becoming very swollen, intumescent, and it will push the iris forward, leading to closing the angle. Or it could be due to ectopia lentis, like there is complete zonular dehiscence, leading to dislocation of the lens into the anterior chamber and closing the pupil. The fourth mechanism is that the angle block is caused by the iris itself, or the iris-induced pupillary block. How does this happen? How a pupillary block could happen with the iris? This happens in cases of aniridia. So in cases of aniridia, most cases of aniridia, they don't, or the misconcept is that they don't have iris at all. But actually, in most occasions, they will have rudimentary iris. This rudimentary iris will be rolled in. So the peripheral iris, in case of aniridia, will be rotated, and this rotation into the angle will leading to secondary angle closure. So this iris, the peripheral iris, which is very rudimentary, so it will be easily bent, it will be easily rotated, so it will rotate until it blocks the trabecular meshwork, leading to angle closure. Okay, so it is here the problem is in the iridotrabecular contact or iridotrabecular opposition. Okay, Dr. Kinana, iris pulled posteriorly. What do you mean? In the second mechanism, why the iris is pulled posteriorly? No, all these mechanisms, the iris will be pulled anteriorly in order to occlude the angle, not posterior. If it is pulled posterior, it will open the angle. It will be something that we will be happy with. Okay, let's now, as we know, we will move now to the closed angle glaucoma. We will start by the primary, then we will move to the secondary. The primary is, we diagnose a primary angle closure glaucoma if there is no secondary cause. So if those patients will have anatomically small eye, so they will have crowded eye. There is a small angle, and this small eye cannot accommodate all the intraocular structures. So that's why they have a short anterior chamber, and they will be more liable to have occludable angle by the iris. So it is expected that it will be more common in females. They have smaller eyes than males, and it is more common in older age group, the same like in primary open angle glaucoma. So it is more common above 40. There is more, they are more liable to happen when the anterior chamber depth is less than 2.5 millimeter. Those who are having hypermetropia and also those who have genetical predisposition. So remember this old lady who has a small eyes, she is hypermetrope, she is putting glasses, and genetics. This will remind you of the risk factors for the primary angle closure glaucoma. Regarding the clinical picture, how does a patient with angle closure glaucoma manifest? Also, the common misconception that it has always to be present acutely. This is one of the presentations, but it is not every case. So let's first start by the acute presentation. Those patients who have rise of the intraocular pressure, so in the exam, you will find this typical scenario of a female who went to the cinema and she was staying in the darkness, and suddenly she experienced halos of light, severe pain, vomiting, and she sought the medical advice. And when you saw her, you found that she has high intraocular pressure, like above 50 or above 60 millimeter mercury. She has mid-dilated pupil, which will be due to ischemia of the sphincter pupillae muscle. And she has also corneal edema because this high intraocular pressure will cause paralysis of the sodium-potassium ATPase pump, which is responsible for drawing fluid from the cornea. And she will have shallow anterior chamber. Maybe you will not be able to appreciate the shallowness of the anterior chamber from the corneal edema, but when you check the other eye, you will find that it has a shallow anterior chamber. So when you examine the angle, you will find that the angle is closed, and this is how you diagnose a patient with acute angle closure glaucoma. So severe pain, ciliary injection, corneal edema, and mid-dilated pupil, vertically oval, and the presence of high intraocular pressure with a closed angle. Sometimes those patients, after the resolution of acute attack, when you examine them later, you will find that there is a whitish opacity at the anterior surface of the lens. This whitish opacity is called glaucom flecken. So what is the nature of this opacity? This is simply the necrosis of the lens epithelium. This is a necrosed lens epithelium, and this happens after the attack of acute angle closure. So this picture, the first one, appeared before in the exams. Second picture also appeared in the exams. So every word here is very important. There is iris atrophy, there is dilated fixed pupil, peripheral anterior synechiae. This is one presentation. Another presentation is, do you remember the presentation of a patient with pigment dispersion syndrome where he had momentary increase of the intraocular pressure, like above 50? So he will experience some pain, mild pain, some discomfort, but mainly halos and the blurred of vision. So there will be like halos and the blurred vision. It is not severe pain, but it's mild pain because there is like spikes. The pressure come and or elevate and depress in spikes. So there is no persistent elevation. There will be like a subclinical attack. So they will only report mild discomfort or mild pain with blurring of vision and the halos. Why the blurring of vision and the halos happen? This is because of the momentary corneal edema, which happens during the spikes of rise of the intraocular pressure, and they will gradually or they will improve. So if the patient sought medical advice, you will check his angle. You will suspect that this patient could have intermittent angle closure. So you might find the presence of irido trabecular contact. Or if a patient is present chronically, so those patients had chronic angle closure. They would have they have intermittent angle closure, acute like successive acute attacks, and they didn't be, or they were not managed. They didn't do any prophylactic measure like PI. So eventually there is the angle is creeping, or there is creeping iridocorneal contact. There will be closure of the angle like 90 degrees, then 180 degrees, then 360 degrees. And in this case, when we examine those patients, we do peripheral laser iridotomy just to eliminate the pupillary block. But however, the peripheral anterior synechiae that happened, it will not be relieved. Sir, what is the mechanism of nausea and vomiting in acute angle closure? It will be just due to the pain. It is the pain, the severe pain that the patient is having, what will stimulate these reflexes. It is not something specific to the glaucoma. So those patients who have acute angle attack, they will have severe pain, and this pain what will induce the nausea and vomiting. Okay, you're welcome. Okay, so let's now talk about how to manage the acute attack. The acute attack is a medical emergency. So we need to have immediate management. Those patients should be admitted and should be positioned in the supine position to allow the lens to shift back, to shift posteriorly, giving them acetazolamide or this carbonic anhydrase inhibitor 500 milligram intravenously and 500 milligram orally after checking the sulfa allergy and the other contraindications that we are going to speak about at the end of the lecture. You also can give the topical beta blocker or alpha-2 agonist in order to decrease the intraocular pressure. Analgesia and antiemetics are required if needed. Then, after you decreasing the intraocular pressure, like for somehow, after 1 hour, you start your miotic therapy. Miotic like pilocarpine 2% 4 times, or maybe some prefer to give it like every 5 minutes for the 1 hour for the first 30 minutes, then 4 times per day in the ipsilateral eye. So what is the rule of the miotic? That they will break this vicious circle of the iris bombae. So the miotic will cause contraction of the iris. It will pull the ciliary muscle from which is attached to the trabecular meshwork, so it will cause opening of the trabecular meshwork. This is one of the few indications of miotics. So miotics are not very common anti-glaucomatous medications, but this is one of the most common uses for them. So why don't we give it immediate? Why should we wait for 1 hour? This is because the miotic will act on constriction of the sphincter pupil. And I just told you that the sphincter pupil is paralyzed because of the high intraocular pressure. So if you just give this treatment immediately, it will not act. It will not cause any effect. You need just to wait until the pressure is a little bit down, so that when you give the miotic therapy, it will be effective. Also, you give miotic prophylaxis in the fellow eye until the prophylactic PI is performed in both eyes. So in such case, when you have a patient, after the resolving of the acute attack, you need to do PI. However, you cannot do it with the corneal edema. So you need first to control the acute attack, then do PI prophylactic from this to prevent this from happening again in the future in both eyes. After 30 minutes, if the pressure is still high, you can give the patient like oral glycerol, and this should be given with caution in diabetics and cardiac patients, or 20% mannitol, which also should be given with caution in patients who have renal problems, giving intravenously over 45 minutes. So these hyperosmolar agents will draw the fluid from the vitreous, causing shrinkage of the vitreous and relieving of the attack if the patient is still having high intraocular pressure. So to remember the management of the acute attack, remember the word MAMA. So MAMA is referring to MAMA, M for miotic, A for acetazolamide, M for mannitol, and the A for analgesia and antiemetics. Okay, so remember this, our old nice lady, Mama. She will be helpful also to remember the management for the acute angle closure glaucoma. After that, the patient should receive Nd:YAG laser, a peripheral iridotomy within 48 hours in both eyes. And surgery is reserved for patients who have like extensive peripheral anterior synechia more than 180 degrees, and they have persistent elevation of the intraocular pressure despite the PI. So those cases should be managed surgically by the trabeculectomy. So this is for the primary angle closure glaucoma. Another category of primary diseases, which will a little bit mimic the primary angle closure glaucoma, and sometimes it will pose diagnostic challenge, is called the plateau iris syndrome. In plateau iris syndrome, it is a primary angle, it is an angle closure glaucoma, and this angle closure glaucoma is caused by here anteriorly positioned ciliary body. So here A is referring to the ciliary body, and the ciliary body is pushed forward. So the ciliary body will push the iris, causing closure of the angle. Okay, so how can we check, or why we should say that it is a plateau iris syndrome, not an angle closure, like a primary angle closure? How can we differentiate? Those patients, like surprisingly, they will have having deep anterior chamber. So when you examine those patients, they will not show the typical shallow anterior chamber like primary angle closure, but they will show deep anterior chamber with a flat insertion of the iris, flat iris plane. And those patients as well, they could have an element of pupillary block. So there could be also an element of pupillary block. It could happen due to the flat iris plane. So still laser peripheral iridotomy could be beneficial in those patients. And those patients also, they are more common in females like primary angle closure, but they are younger. So it will be more common in 25 and 30-year-old, and they don't have to be hyperopes. They don't have to be highly hyperopes, as the hyperopia is linked to the shallowness of the anterior chamber. So here is like there is an abnormality in the anterior segment with anterior displacement of the iris caused by forward displacement of the ciliary body. So how can we diagnose it, or what is the diagnostic sign? It is called the double hump appearance. Double hump appearance, you see that there is a hump here at the site of the arrow by gonioscopy. Then there is concavity of the iris, which means that the iris here is a little bit, the plane is flat. And there is another hump at the angle. What is this hump? This is simply the iris which is pushed by the ciliary body. Ciliary body is pushing the iris, causing occlusion of the trabecular meshwork. So this is very important and asked before. This slide appeared before in the exams, is the double hump appearance in gonioscopy and UBM. The treatment here is long-term miotic therapy. So miotic therapy again will pull the iris away from the angle, or iridoplasty. So iridoplasty is by making thermal burns at the iris. These burns will cause contraction of the iris and pulling the iris away from the angle. Also, those patients could have an element of pupillary block. So the treatment will be to do them laser PI to relieve this pupillary block. Okay, clear? The double hump appearance, let me show it to you. So you see, this is the edge of the pupil. You see this curvature. Yes, it can be diagnosed also by the UBM. This is a UBM. So this is the double hump. This is one hump. And you can see that the iris here is flat. For all this is flat. So this is the first hump. And this is the second hump. Got it? This is caused by pushing of the peripheral iris by the sphere body. Clear? Okay, you're welcome. Okay, so let's now move to the next topic, which is the phakomorphic glaucoma. In the phakomorphic glaucoma, it is caused by an intumescent lens. So the lens is becoming swollen with water. There is water vacuoles, and it is becoming increasing in the interlenticular pressure. So it will push the iris until it will make the anterior chamber shallow. So eventually it will close the angle of anterior chamber. So how can we know that it is an intumescent cataract? First of all, check for the lens. You will find that the lens is intumescent, that the lens is swollen. You can find the water vacuoles present within the lens by close observation. And also simple that you should compare between both eyes. So compare this eye to the other eye. You will find that the other eye is completely normal. There is no shallowness of the anterior chamber. And this means that the lens here is the cause of shallowness of the anterior chamber. So what will be the management if the patient has acute eye like that? So it should be managed medically, as we mentioned last time. We need to do the like anti-glaucomatous medications, and if there is inflammation, there should receive steroids. And if the patient has quiet eye, then we may consider peripheral iridotomy, but usually it is not necessary. Like, why should we why we do iridotomy if the patient should eventually receive cataract surgery? So the treatment here is the cataract removal, while the PI, it will be unnecessary because it is a temporary measure. So cataract surgery is the definitive management and in the eyes that have potential for improved vision. Usually in those patients, we will go through the pars plana doing limited anterior vitrectomy in order to shrink the vitreous and to make the anterior chamber more deep to facilitate the cataract extraction. So this will be another intraoperative measure to deepen the anterior chamber to try to facilitate the cataract removal. Another form of the angle-induced glaucoma will be the ectopia lentis. We discussed it before, that it will be there is displacement, anterior displacement of the lens in case of zonular dehiscence leading to pupillary block. So what will be the immediate management? To do cycloplegics, trying to dilate the pupil to prevent the pupillary block. Another measure, we can do peripheral iridotomy. But in this case, we do 2 laser peripheral iridotomy, 180 degrees apart. Why? Why 2? Why not 1? Because the lens is mobile, so it can easily block any one of them. So we are just doing it 2 as a temporary measure so that if one is blocked, the other will be functioning. Another cause of the angle closure glaucoma will be the new vascular glaucoma. So a new vascular glaucoma is simply the presence of anterior segment ischemia, which results from posterior segment ischemia. So those patients, mostly they have, or most cases are due to central retinal vein occlusion or the proliferative diabetic retinopathy. Other cases could be due to ocular ischemic syndrome or due to sickle cell retinopathy or other vascular retinal diseases. But 50%, around 50% develop a new vascular glaucoma after ischemic central retinal vein occlusion. This number was asked before in the exams. 50% of patients with ischemic central retinal vein occlusions may develop new vascular glaucoma. In those patients, they will have blood vessels creeping over the iris, creeping over the angle, so it will cause new vascularization over the iris, new vascularization over the angle, and then these will invite fibrous tissue. They will cause fibrovascular membranes. These fibrovascular membranes will contract, leading to peripheral anterosynechia. In those patients, the peripheral anterosynechia end at the Schwab's line. We will try summarize the relation between the peripheral anterosynechia and Schwab's line in different diseases, but focus on that because this is also asked in the exams. The relation between the peripheral anterosynechia and the Schwab's line. Here in the neovascular glaucoma, the peripheral anterosynechia ends at the Schwab's line. In those patients, the neovascularization at the angle could occur before the neovascularization on the iris, and those need the treatment is to do heavy PRP whenever possible. So heavy PRP before glaucoma surgery, even if the angle is totally closed, because this heavy PRP, what will target the pathology? The pathology is a posterior segment ischemia. So this ischemic retina will release VEGF, which will result in new vascularization in the iris, new vascularization in the angle, and so this will PRP will kill this ischemic retina. So this will be the treatment. So in order to know or to have like a flow chart how to manage a patient with neovascular glaucoma, we first need to know what will be the cause or what was the cause. Is this patient a diabetic, so he needs a diabetic control, or he had vein occlusion, or he had ocular ischemic syndrome? So we need to investigate and treat the underlying cause, and then control the acute attack. So those patients usually have presenting by severe pain, acute eye, injected eye, and usually they are blind. Like you will recognize those patients once they enter into your clinic. He will be dragged by any of his relatives or his family, and he cannot see because this is usually bilateral condition. And they will give a long history of diabetes, or going to doctors and treated for doing injection or doing laser, or even neglecting the medical treatment altogether. So how to control this acute attack? You need to control both the inflammation and the intraocular pressure. You control the inflammation by atropinization. So this patient should receive cycloplegic like atropine, typically atropine, and receive topical steroids to also decrease inflammation. To decrease intraocular pressure, beta blockers and acetazolamide will be sufficient. But for some cases, those patients may need mannitol. And the important thing here is to know what to avoid. What to avoid is you should avoid the miotics and the prostaglandins analogs. Those drugs can increase the inflammation. Miotics and prostaglandins analog cause breakage of the blood-aqueous barrier, bringing more inflammation, inflammatory mediators, bringing more plasma proteins. So it will worsen the condition. And also the prostaglandins analogs by themselves, they are analogs to the prostaglandins. You see, when we are giving a patient an anti-inflammatory medication, these anti-inflammatory medications or the analgesics are based on that they are anti-prostaglandin. So when we are giving prostaglandins to those patients, you are giving pain mediators toward at their eyes. So it will worsen the pain. Pan-retinal photocoagulation, if possible. So here is that you need to, this medication that you gave to the patient is just to prepare him for the definitive management, which is the pan-retinal photocoagulation. This what will target the pathology. But sometimes those patients could have very small pupil from fibrosis and posterior synechia. So in those patients, you may consider anti-VEGF. Then after that, you decide if the patient has useful vision or not. If the patient has useful vision, like he is presenting early and there could be some good visual prognosis, then if there is complete regression of the neovascularization with PRP, then you can do trabeculectomy with mitomycin. However, this usually has a very, very high failure rate. So trabeculectomy in an inflamed eye, this usually end by failure. But this is theoretically, if there's complete regression of new vascularization with PRP, then you can do the trabeculectomy and trying to increase the success by mitomycin. However, if new vascularization is still present, and this is usually the case, the treatment will be the valve surgery. But unfortunately, many of those patients present late, and as I told you, they present blind, so they will have like no PL vision. So in those cases, we just continue the medical treatment just to relieve the pain, not for the sake of vision. So continue the medical treatment if the patient comfortable with that, but just avoid long-term acetazolamide. It will cause like bony aches and prostration. So just avoid long-term acetazolamide. Shouldn't be given for more than 1 month. If it's still painful, then those patients could do cyclodestructive procedures such as cyclodiode photocoagulation. And if there is still pain, retrobulbar injection of alcohol to kill the ciliary ganglion will be an efficient way to manage this pain. Okay, Dr. Yahya, you are treating ankle closure glaucoma. What do you mean? So please, Dr. Yahya, elaborate more, and we will go through. Everything is clear here? Everything so far so good? Yes, Dr. Selma is also suggesting another way for management is to do cryotherapy for if you cannot do PRP, so you can do the cryotherapy. Yes, I agree. It could be another possible way of management. So it can be useful to coagulate, to do cryotherapy for the new vascularization. The only problem for the cryotherapy, it will be extremely painful for the patient. I'm meaning after he will be after the local anesthesia effect, he may experience more pain. But yeah, I agree. It is still valid way of management. Okay, so let's now move to a very important topic, which is called the ICE syndrome. ICE syndrome, it is called iridocorneal endothelial syndrome. Dr. Roxana, is there any recommendation of anti-VEGF in the anterior chamber? It can be attempted as well, but it shouldn't be given alone without posterior chamber anti-VEGF, because the pathology is in the posterior chamber mainly. Okay, so if you are going to give anterior chamber anti-VEGF, it should be combined with the posterior as well. Again, back to the ICE syndrome, it is called iridocorneal endothelial syndrome. So if you think about it, about the name, it's iris, it is a syndrome involving the iris, involving the corneal endothelium. So the problem for those patients is that they have some sort of abnormal endothelium. This abnormal endothelium appears like beaten bronze appearance. Beaten bronze is the same way like the Fuchs endothelial dystrophy. So when you see this patient in the first instance, you consider that it could be a Fuchs patient. However, this patient is presenting with unilateral. This is only one eye, not both eyes, not bilateral, like in typical Fuchs endothelial dystrophy. And also, they usually affect females who are at younger age from the age of Fuchs endothelial dystrophy. So those patients have abnormal endothelium. This abnormal endothelium with beaten bronze appearance will lead to corneal edema, and it is called iridocorneal endothelial syndrome. So the iris will be also affected, resulting in iris atrophy like that. and they also have secondary angle closure glaucoma. So starting about the secondary angle closure glaucomas, one of them is the ICE syndrome. This is because of the abnormal endothelium which will creep over the angle and it will cause peripheral anterosynechia. Speaking about the peripheral anterosynechia has a very important character here. It is a high peripheral anterosynechia. This peripheral anterosynechia extends anterior to the Schwalb's line. Very, very, very important and asked many, many times in the exams. The peripheral anterosynechia here extends anterior to the Schwalb's line. Okay, it is high peripheral anterosynechia. So does it mean that there is high intraocular pressure? Well, intraocular pressure, first of all, doesn't correlate with the peripheral anterosynechia, and also not in every case. It is around 50% of patients. So when the exams tell you that this patient has normal intraocular pressure and you see the picture of iris atrophy like that with typical age of unilateral in female between 20 to 50-year-old, you say that it is, I heard the ICE syndrome in the chapter of glaucoma, so it is, and this patient has normal intraocular pressure, so it is not glaucoma. No, it is still, the patient has 50-50 chance to have normal intraocular pressure. If the patient has glaucoma, then there are some variants of this disease. They are called essential iris atrophy, iris nevus or Cogan-Reese syndrome, and the Chandler syndrome. The glaucoma is more severe in the essential iris atrophy, iris nevus, and Cogan-Reese syndrome. However, the third one, which is the Chandler syndrome, it has more corneal affection. So remember, cornea is more severe in the essential iris atrophy, iris nevus, or Cogan-Reese syndrome, while the corneal affection is more in the Chandler syndrome. So for the treatment, this is one of the resistant glaucomas, so unlikely that the medical treatment will be sufficient or effective. So they will need aggressive management, like even the trabeculectomy alone will not be sufficient. This is one of the resistant glaucoma, the intractable glaucomas. So usually for those patients, the treatment of choice will be the glaucoma drainage device. Speaking about the variants of the ICE syndrome, let's see what are the differences so that you also know how to reach a diagnosis. First of all, the Chandler syndrome. The Chandler syndrome, this is the commonest type among all ICE syndromes. It's accounting for 50% of all cases. Remember C for C, Chandler, C for cornea. So in Chandler, C, there is more corneal affection. There is corneal edema. So, and what makes the diagnosis of this case is difficult that most of those patients will not have any iris changes. So you see, it's called iridocorneal endothelial. So you are expecting to find iris atrophy, polychoria, but this is not the case. Most of those patients don't have any iris changes. So how can you suspect? You will suspect by the presence of beaten bronze appearance. It also suspected by, you must say, but there is corneal edema. Sometimes the corneal edema is subtle in such cases. So you may be able to appreciate the bronze beaten appearance, and it will be unilateral in young female. And if you have high index of suspicion, then you will do gonioscopy, and you will find the high peripheral anterosynechia. So you will reach a diagnosis in the ICE in the Chandler syndrome. Another variant is called the essential or progressive iris atrophy. And as the name implies, the more prominent feature will be iris atrophy. So the iris atrophy, iris findings are more prominent, more progressive over time. So there will be polychoria, multiple pupils, correctopia, displaced pupil, iris hole formation, ectropion UV, and iris atrophy. A third variant will be very characteristic. It's called the iris nevus or Cogan-Reese syndrome. The iris nevus, there will be unique iris finding that you will find the iris surface has like pedunculated nodules. There are nodular or mammillated surface of the iris. So, or it could be like diffuse pigmented lesion. So for mammalization, it will be like Cogan-Rees syndrome. For the diffuse pigmented lesion, it will be the iris-Nevus syndrome. And in those patients, iris atrophy is uncommon. So you may find again the beaten silver appearance, and with this characteristic picture, you will diagnose an iris-Nevus or Cogan-Rees syndrome. Okay. Dr. Islam, difference between Chandler and Fuchs? Yeah, I just said that in the Fuchs, it will be more common in old females, like above 40, while in the Chandler, it will be between 20 to 25 to 40. And both are common in females, while the Fuchs, it will be bilateral. In the Chandler, it will be unilateral. In the Fuchs, it will be high intraocular pressure could happen at both of them. Both can be present with high intraocular pressure as well. But the striking difference, it will be the doing gonioscopy. So in the angle, in the Fuchs, it will be normal, but in the Chandler syndrome, it will show the high peripheral anterior or more anterior high peripheral anterosynechia. Okay. So speaking about the peripheral anterosynechia, peripheral anterosynechia have certain characteristics which will help in diagnosis. For the uveitis, it will be inferior, non-uniform in height or shape. In eyes, it will be anterior to the Schwab's line, as we mentioned. In neovascular glaucoma, it will end at the Schwab's line, as we mentioned. In chronic angle closure, it will be circumferential and decreeping also, as we mentioned. So here is again a patient with eye syndrome. So you see here are the angle structures are visible. However, you see here, here is high peripheral anterosynechia. There is all structures of the angles are obscured here with high anterior peripheral anterosynechia more anterior to the Schwab's line. So it is becoming more anterior than the most anterior structure of the angle. So this is the characteristic feature of peripheral anterosynechia. Another cause of secondary angle closure, it will be the aqueous misdirection or the malignant glaucoma. So what is the theory or what is the problem in malignant glaucoma? And why we call it malignant? Here is there is a problem that there is rotation of the ciliary body. The ciliary body will rotate forward, and by rotating forward, this is like rotation of the ciliary body forward, meaning that it is a ring. So rotation of the ring forward will make the ciliary process secrete the aqueous posteriorly. So the ciliary process will be directed posteriorly, leading to that the aqueous will be directed toward the vitreous instead of the posterior chamber. So this will lead to increasing in the volume of the vitreous. This will result in pushing the lens and the iris diaphragm forward, leading to shallowness of the anterior chamber and the closure of the trabecular meshwork, leading to rise of the intraocular pressure. Malignant glaucoma can happen after any intraocular surgery. It can happen with phakic intraocular lens implantation, phacoemulsification, trabeculectomy, penetrating keratoplasty. So especially if there is history of that this patient had angle closure or peripheral anterosynechia. In such a case, as you see, the angle is thin or absent uniformly, that there is shallow or absent angle in the center and in the periphery. And it could happen in both patients who have pseudophakic or phakic eye. So why we call it malignant? Because when you say something it is malignant, this means that its growth is unstoppable. When there is a tumor which is growing and you cannot stop, you are unable to stop the growth of this tumor. And again, here you are the aqueous is secreted all the time, and so it will cause increasing in the vitreous volume all the time, and you are not be able to stop. So how can to break this circle? First of all, use cycloplegics. Cycloplegics will help in this rotation of the ciliary body, and it will help to dilate the pupil, so avoiding any pupillary block element. And you should avoid any myotics, because myotics will result in increasing the pupillary block and also will lead to iridocorneal touch like that. and what will compromise the corneal endothelium. Also, if this is alone is not sufficient, then you should go for another modality, which is called YAG hyalotomy. YAG hyalotomy is doing YAG laser to disturb the anterior hyaloid face, like to make small opening into the anterior hyaloid in the vitreous by the YAG laser, allowing escape of the excess fluid so that you are breaking the vicious circle and allowing that this fluid may pass through its anatomical pathway. If these are not sufficient, then the final measure is to doing vitrectomy. So we are just doing vitrectomy, removing all the vitreous, and this will be helpful to make the iris lens diaphragm return backward. Okay, so this is called the aqueous misdirection or malignant glaucoma. Another case of secondary angle closure, it's called the epithelial or fibrous ingrowth. So in those patients, they will have epithelium migrates through the wound and proliferate in the anterior segment. So after doing a surgery, which will include a full thickness corneal incision, like penetrating keratoplasty, like extracapsular cataract surgery, you may induce or you may implant accidentally some epithelial cells into the anterior chamber. So these epithelial cells, you know that the epithelium has a tendency to proliferate excessively and unstoppable. Again, it is unstoppable. So this will result in appearance of pillows, sheets, or cysts of epithelium, which are growing below the cornea. And they are also growing on everything. They will grow on at the back surface of the cornea, will grow at the angle, causing adhesions and causing traction over the angle with the angle closure, and also will grow over the iris. So this will be one of the highly resistant glaucomas. Like this disease is really catastrophic because there is epithelium in the anterior chamber and you are unable to stop it from growing. So how can we diagnose this? What will be the risk factors is prolonged inflammation, wound dehiscence, delayed wound closure, and Descemet's stare. And diagnosis for this condition was asked before in the clinical ICU exams is how we diagnose epithelial or fibrous ingrowth. It will be by argon laser. So by doing mild laser burns by low power over this membrane, this will result in whitening. If the membrane or if you are suspecting a patient with epithelial downgrowth and you do this argon laser low power, and it will find there is whitening of this membrane or blanching, this means that this membrane is epithelial ingrowth. Treatment is to do radical surgery, like to do corneoscleral graft, trying to replace everything like the cornea, the sclera as much as possible, the angle, and use a tube, which is usually fails. Another case of a secondary angle closure glaucoma, it's called the nanophthalmos. And as we mentioned before, that the nanophthalmos is a normal shape but small eye. So it has a normal anatomical arrangement, but it is just a very small eye. So those patients will present with hyperopia more than 10 diopters, and they will have a short axial length less than 20 millimeter with relatively normal lens. And this is the problem, that the relatively normal lens is bulky. It is huge in comparison to this very small eye. So that's why those patients will have a very shallow anterior chamber. They will have more tendency to develop pupillary block. They will also have uveal effusion. And why they will have uveal effusion? Uveal effusion occurs because they have thick sclera. And thick sclera, there are the opening of the vortex veins are like around 4 millimeters behind the equator and the sclera. So the thick sclera will cause obstruction at the drainage of the venous drainage. This will result in engorgement of uveal tissue. As you know, the blood vessels are in the uvea, result in uveal effusion. This again will cause glaucoma. So how to manage? Usually those patients are not responsive to medical treatment. So medical treatment will not be very effective. So the goal of treatment here is to prevent the peripheral enterosynechia. So if they have pupillary block, we need to start early to do PI to just to treat to do PI in the iris. It may help to break the pupillary block. Also, we do to do iris iridoplasty. This iris iridoplasty also could cause contraction of the iris and pull the iris away from the angle. So this will be initially, but if the peripheral enterosynechia happens, then no, there we need to do surgical intervention, more invasive, like to do trabeculectomy, sclerotomy, or lens extraction. As we will say later on, the lens extraction will cause that the small eye will be capacious. So you are removing the bulky structure from the small eye, so causing widening of the anterior chamber. So this will be a proposed method for management of angle closure due to small shallow anterior chamber, as we are saying in the EAGLE study. Another cause of angle closure, it be the retinopathy of prematurity and persistent fetal vasculature. So those patients will have contracted retrolental tissue. This retrolental tissue will cause a shallowness of the anterior chamber. You see the contraction here in the persistent fetal vasculature. It will cause elongated, prominent ciliary process. You see, very clear. Occurs usually at the age of 3 to 6 months, and angle closure may also happen later in life. So, and the key in those patients again is to prevent peripheral enterosynechia by interference for the primary pathology, like retinopathy of prematurity or persistent fetal vasculature, and also by doing synecholysis into the anterior chamber to prevent the synechial closure. Finally, there is some drugs which can cause glaucoma, angle closure glaucoma, and this also asked many times in the exams. This drug is called the topiramate. Topiramate is an antidepressant. One of the side effects of it that it will cause acute myopic shift because it will cause bilateral angle closure by ciliochoroidal effusion. So this drug will cause relaxation of the zonule, leading to forward movement of the lens, ciliochoroidal effusion. This ciliochoroidal effusion will push the iris forward, leading to angle closure. So for those patients who have bilateral ciliochoroidal effusion, like diagnosed by the UBM, we should inquire about the drug history because they could be on topiramate. The treatment is to stop the topiramate or Topamax and start the treatment with cycloplegics. And this is not only occurring with the topiramate, but it also occurs with other sulfa-based drugs. Okay.